I'll look into his stuff.
I'll tell you about it. Yeah, right. I wish I could cite one of his articles. He wrote some early stuff on polio too. And he was open-minded to new things, and really he gave Sister Kenny a big send-off with some academic study and some of the work that she had done, and so I'll talk a little about that too. So history is interesting.
It is.
Yeah,
It is.
we've had a great community for orthopedics here, and it's growing. I mean, we got a continuing fabulous program for training.
Yeah.
You guys are doing great. So
I agree. Lauren, shut the door. You want to?
get the announcement. You got the announcement?
Yeah, I do. Oh, do you want to do it?
Right. I'll do it. Good morning. Eager residents to learn. It's wonderful. Paucity of faculty. I guess everybody over that normally is on this side thinks they're authorities on the cavus foot, but I don't think they are. So we're glad that Ben is here to talk to us this morning. A number of announcements. Next Friday, no grand rounds, July 5th. Unless those of you who are in the emergency room have to take care of a few blown off thumbs from people who don't throw the firecracker quickly enough. So that happened. July 12th, anticoagulation and orthopedic surgery, what you need to know, by Ryan Lilly. Following 19th, Gillette Ortho Fellow presentation, Ryan Farmer. 26th, fellowship presentation by Stuart Morrison. August 2nd, Orthopedic Heritage, 500 years as a department, a division of surgery until 1969, presented by me. I'm the only one that's been around that long. And on the 9th of August, updates on acetabular fracture surgery. So there are some interesting things coming up as the front row over here is just, I'm not sure if there's a 5-row hierarchy. I'm glad to see the fives be able to move over to the center because, you know, that's your territory. So, well, fours can be here. Anybody can be here. It doesn't have the sign-up sheet is out in the back for faculty. Core curriculum, hand fractures, Ariel Williams, at least I'm sure you came because you're interested in hand, so that's good. Grand rounds, understanding cavovarus foot. And Ben has been one of our stars, highly recognized for all of his creative things. And he's been a real innovator, and I'm sure most of you know all those things he's done. And use him for some inspiration, and don't let him stand alone in those special honors. So Ben, we'd like to hear from you. He's from University of Michigan, which we won't hold against him. So.
All right. So these are the truly passionate foot and ankle folks in the audience. So I'm going to go through a small background, some of the etiology, epidemiology, the anatomy, biomechanics, a few procedures, and where to go going forward with this disease. So it was first described in 1741, and it was called a bolt foot, most likely based upon how rigid the foot was. It was then described in the American literature in about 1885. So the pes cavus describes a foot that has a higher than normal arch. Other terms that are used are cavovarus deformity, claw foot, supinated foot, equinovarus, and equinocavus foot. And on the radiograph, findings, increased calcaneal pitch, plantar flexion of the metatarsals, and varus hindfoot are the most common findings. The etiology, it can present in childhood or adulthood, rarely before the age of 3. It's progressive or fixed, depending upon the underlying cause and its severity. And it can be divided into numerous different main groups. The most common is about 4. Neurologic, traumatic, residual clubfoot, idiopathic, and then everything else in other category. It's most frequently caused by muscle imbalance, a unbalance of the intrinsics and or loss of function of the intrinsic muscles of the foot. The motor imbalance begins before, if it does begin before the age of maturity of the skeleton, this can lead to changes in the bony morphology itself. In post-traumatic conditions, this usually results of bony deformities and or ligament instability. So this review paper in JAOS, they broke it down into 3 groups, where they included the idiopathic residual clubfoot into the category of others. So the main 2 basically are neurologic and traumatic. In the neurologic group, CMT is the most common. Also referred to as hereditary motor sensory neuropathies. For CMT, there's over 17 different gene variants that have been found at this time. And some of them are autosomal dominant, some are recessive, some are X-linked variants as well. Again, probably about 10 to 15 other types of genetic conditions here too. The muscle imbalance mostly in these conditions are an agonist-antagonist pair mismatch. So there's a weak anterior tibial tendon, a muscle, and a strong posterior peroneus longus that leads to plantar flexion of the first ray, and then a weak peroneus brevis and a strong posterior tib tendon muscle complex, which leads to the high arch and varus deformity. Furthermore, the peripheral neuropathy in these conditions leads to weakness of the intrinsic muscles. The extrinsic flexors and extensors overpower these weaker intrinsics, leading to flexion of the IP joints and hyperextension of the MTP joints. In traumatic, compartment syndrome of the deep posterior compartment leads to contraction of the posterior tibial muscle and flexor muscles, which leads to an equinus and cavus deformity. These muscles contract, pulling the foot into an equinus and cavus position. Again, further scarring, burns, crush injuries, and venous stasis can also lead to similar presentations. A talar neck fracture, malunion, is another common traumatic cause. Leaves the foot in leaves the talus in a displaced position that leaves it shortened, dorsally, medially translated. And these are all basically the position of a cavovarus foot. Injury to the deep branch of the peroneal nerve or L5 nerve root as well. And then long-standing heel varus for whatever reason can lead to injuries to the surrounding tendons, rupture, and then eventually into a deformity. For congenital, usually it's just untreated or partially treated clubfoot, and this again can persist and lead into the adult type. For idiopathic, again, underlying cause not found. This accounts for roughly 1/3 of all the cases. That being said, a lot of the genetic patterns of some of the hereditary motor sensory neuropathies actually have not been uncovered yet. So a lot of these actually could be under that category. And additionally, there's a type of normal variant called a subtle cavus foot that kind of straddles the line of cavovarus and then also just normal. So I'm going to try to describe sort of how this deformity takes place and sort of how it looks. It's a little complex. So I tried to do it in several different ways to make it clear. So again, based upon the etiology, again, plantar flexion of the first ray is forefoot driven, deformity of the hindfoot is hindfoot driven, or can have a combination of both. So it's basically the 2 different types of deforming forces that you can have. So the forefoot driven deformity, for whatever reason, the first ray flex in the lateral view. So you can see that on A over here. When the foot is unloaded, the hindfoot's actually in a neutral position. But whenever the foot is loaded and the person's weight bearing, there's a compensatory varus tilt to the hindfoot. And the reason behind this is the foot is a tripod. There's the heel, there's the first metatarsal head, and there's the lateral forefoot. All those have to be on the ground for a plantar grade foot. That's where the foot wants to go. And so if you do have some deformity somewhere, it's going to try to compensate to make that. And so if a forefoot-driven deformity, that's what you get. Hindfoot-driven deformity caused by deformity or malalignment of the hindfoot. Again, tendonic fractures, calcaneal fractures. In this case right here, I guess the lighting's okay. You can see that this first metatarsal is off the ground. So there's no way that is actually contributing to this deformity. So either it's a fixed deformity, there's something in the hindfoot that's driving what this patient's experiencing. The mechanical changes, the axis of the talus and calcaneus become more collinear. So in this image below, this is a normal foot, this is a flat foot, this is a cavus foot. So you can see as you progress from a flatter to a more upright or rigid foot, that these two bones, the talus and the calcaneus, sort of transition into more of on top of one another. Once they move into this position right here, which we'll get into what normal gait is as well and how this kind of affects that. But this position is a very rigid foot. This is a very flat and supple foot. So as it goes to this point right here, the hindfoot locks in an inversion position, less subtalar joint and transverse tarsal joint motion. And what the biggest issue is here is the ability of the foot to actually absorb the energy from gait is diminished substantially. And so over time, the first metatarsal head, lateral board of the foot become overloaded, and you get substantial changes and pain and deformity as well. So here is looking at it from different angles. This red box is highlighting the cavovarus foot here. This is normal. So this yellow coloring is the contact area of the navicular on the talus. So you can see how this is just for reference, how the navicular is way off medially compared to the talus in a cavus foot, whereas in a normal foot, much more aligned. In a flat foot, it's just the opposite direction. Can't have a talk about feet without plantar pressures. So the total contact area between the metatarsal head and heel pad is decreased, which means that there's a higher pressure per area in each of those locations. So this image on the left here, a little confusing, but basically it's comparing the first foot to the second, and the red is where the pressure changes are higher for the first foot. So in a cavus foot compared to a normal foot, there's substantially higher pressures at the first metatarsal head, lateral forefoot, heel. And the other ones are just for flat foot and normal. This is a progressive deformity from an injury in a patient that was presented in a paper as well. So the changes seen in the forefoot is due to the hyperactivity of the extrinsic flexors and extensors. So the extensors lead to a cock-up deformity of the MTP joints and clawing of the proximal and distal IP joints. So in this foot right here, this is the first ray. The extensors are pulling on the proximal phalanx and the flexors are pulling on the distal. So it leads to this cock-up deformity and clawing of the toes. This increases the slope of the metatarsals. It also decreases the plantar fascia length, leading to fibrosis and shortening of it as well. Over time, these MTP joints can actually dislocate, and the actual plantar fat pad, which is below the metatarsals, which helps with dissipating pressure during walking, actually displaces anteriorly or distally, leading to increased pressures below the metatarsal heads and pain there as well. And furthermore, the toes no longer participate in weight bearing or toe off, and so power from walking is actually diminished substantially. The changes in the Achilles, this I think is the most interesting part of it, is as the foot progresses into a varus deformity, the Achilles tendon starts acting more of a inverter. So the lever arm of the Achilles tendon increases and its vector medializes. So on the left here, we'll start actually with the right. So this is a normal hindfoot. You can see that the red line that I drew is basically in the center of the calf going down, and the force that this is pulling is slight valgus here. When you have a cavus foot, you can see that the Achilles tendon vectors actually move medially, and so this force is in a positive feedback loop, increasing the deformity, and as the deformity increases, increasing the pull of that tendon in that direction. Other changes just in general, the plantar fascia acts as a windlass mechanism. So basically, as the foot is at rest, in this example right here, and then moves into a toe-off position with the toes extending, the plantar fascia tightens, increasing the longitudinal arch. In a cavus foot, this is always present. So the foot is never at rest, and so the arch is continuously being elevated. The metatarsals are consistently being plantar flexed, and the fascia becomes contracted over time as well. Furthermore, metatarsal adductus contributes to this deformity, overloading the lateral side of the foot as well. So again, just sort of the progression of the deformity overall, plantar flexion in the first ray becomes fixed, the short part joints become locked, no longer functioning, intrinsic muscles are weak, the extrinsic muscles, flexors and extensors are overpowering them, the Achilles tendon becomes a secondary inverter, and this is a constant feedback loop here. This diagram in one of the papers that I was reading, I thought was actually great. So A is a normal foot. B is an early stage of a cavovarus foot where the intrinsics have started to fail, and this is causing contraction of the plantar fascia. The peroneus longus PL is pulling the weak anterior tib. The foot's going into more of a varus position. As this progresses further down, the plantar fascia is becoming more and more contracted. The EHL is trying to compensate for the tibialis anterior. The Achilles tendon has moved into more of a medializing position, and then you get this more substantial, severe progression down here. In the axial plane, the posterior tibial tendon, peroneus, and Achilles tendons are the main driving forces for this deformity. And again, as they move into their position, it's more of this positive feedback loop. Overall, what patients are experiencing is metatarsalgia, basically increased pressure of the metatarsal heads, fifth metatarsal stress fractures, plantar fasciitis, medial longitudinal arch pain, and as you're getting more and more of a cavus foot, the lateral ligaments are becoming more and more unstable. There's again, there aren't very many studies on the clinical patients of these, but there's a lot of biomechanical studies. The findings are that as this deformity progresses, the talus is changing its position within the ankle mortise, and so it becomes more dorsiflexed and it increases the anterior impingement. As this happens, there's actually increasing loading on the anteromedial area of the ankle joint. And as this happens, there's sort of a theory that you get more and more ankle arthritis in this area, and additionally, more and more instability or laxity of the ankle ligament structure. Over here, as this is looking at the basically the plantar flexion of the first ray. So this is a neutral, 15 degrees, 30 degrees of plantar flexion. As it increases, the pressure in the anteromedial component of the ankle increases as well. So Gait, just briefly through the different stages of it. So dividing this two phases, stance and swing. Stance is 60%. In the stance phase itself, there are four specific divisions: heel strike, mid stance, terminal stance, and pre-swing. Complex slide. Goal is just to introduce the fact that the first interval is initial heel strike to the foot being flat on the floor. Second interval is the foot flat, and as the body passes over the foot. And the third interval is as the foot moves into more of a position to be in a rigid foot for powering off into the swing phase. So first phase, heel strike to flat foot. The calcaneus rapidly inverts. Whoops. Calcaneus rapidly inverts. And the longitudinal arch flattens. This is through the subtalar joint that most of this motion is happening. As they move from supination to pronations, become more of a supple foot. And the point of this is to lessen and dissipate all the forces through the foot. This does not happen in a cavovarus foot. On the right over here, the red line is a normal foot. So you can see that there's substantial pronation through the subtalar joint, whereas in a cavus foot, this is really limited to none. In the second interval, the foot's going from flat foot and to more, again, to the area of capable of weight bearing. Again, subtalar joint progresses through this area, but the hind foot at this point is starting to invert, getting ready for push off. That is not happening in a cavus foot because the foot's already in that position. And then in the final phase for toe off, the foot's already ready to be in a rigid position, so the normal foot is there as well. So here's a video of, hopefully this plays. So I was hoping to be able to control it more slowly, but as you can see, the foot, as the heel strikes and goes into push off, the heel is inverting quite a bit. Whenever the heel strikes the ground, it's pronating a lot, dissipate the forces. As toe off, it's becoming more rigid to create a very strong lever arm. So patients usually present with pain, occasionally with deformity, but usually their presenting symptoms actually is pain. And that's, again, due to the increasing stress and overloading the lateral foot and the first metatarsal head. Again, presenting with stress fractures is not uncommon. Patients will also present with lateral ankle instability, and that's due to the continual overloading of the lateral ligament complex. Metatarsalgia as well. Family history is incredibly important to get. Usually these patients have family history, any history of trauma to the lower extremity. Assessing the patient walking clinic is also quite important as well. And of course, the neurovascular exam is really important, but also figuring out which muscles are actually functioning and at what strength, which ones are not, is key, because that's going to drive your treatment options going forward. Testing the Achilles contracture versus a gastroc contracture is important, because that's going to direct your treatment algorithm as well. So here's a patient with a cavus foot standing in different positions. You can see on the front view that this medial heel is a little more prominent than normal. So it's someone called a peekaboo sign for whatever reason. On a hind foot view, the hind foot is much more varus position. As the patient's standing on their toes here, this is much more of a varus position than normal. Patients will stand with varus, but this is substantially more than they should. On the lateral view, you can see the arch is a little bit higher, and this is, at least on my computer, really red and irritated due to continual walking on that side. Everyone's probably heard of this test, but maybe not know what it's for or why we do it. It's to differentiate between a forefoot-driven deformity and a rigid foot or a hind foot-driven. So with this block under the distal lateral forefoot. And a positive test is the heel varus corrects when standing on the block. So in this case right here, cavus foot when standing without block corrects whenever standing on the block. This indicates that the deformity is due to the first ray being plantar flex. As you can see, the ray is plantar flexed here, but they're able to compensate now with this block being under the foot. The negative test is patient standing on the block and nothing happened. Nothing changes in the hindfoot itself. So this is indicating it's more of a hindfoot-driven deformity. X-rays here. So a AP of the ankle on the left here shows much more overlap of the fibula and the tibia. You have to get a good X-ray to see that, I guess. On the lateral here, looking at two of the angles, one is the talar first metatarsal angle, which is called a Meares angle in A, and then B is the calcaneal pitch. Both of those are substantially increased in a cavus deformity seen here. On AP of the foot, you can just tell just by looking at this does not look right. Metatarsus adductus and the tenonavicular joint is, at least the navicular is displaced medially quite a bit there. So a lot of words on the slide, a lot of bubbles. Basically, a general algorithm to treat these patients. So first is, do you have a cavus foot? Yes or no? Yes. Use a colon block to determine if it's forefoot driven or fixed. We'll go with it's fixed first. And the patient also has arthritis. That's actually a pretty easy decision. It's a very hard surgery, but a pretty easy decision to make at this point. So basically that's moving towards more osteotomies and a triple joint or some sort of joint fusion. If the foot is fixed, but there is not significant arthritic changes, you start with the hind foot and you work your way forward. So you start with a lateralizing calcaneal osteotomy of some sort, and then you're going to do some sort of tendon transfer to fix the underlying pull issue of the tendons. As you kind of move down, you add more and more things, including plantar fascial release, Achilles lengthening, or gastroc release as well. If the foot is flexible, you start with the forefoot and you move towards the hind foot. So you start with a first ray osteotomy. Again, transfer tendons to correct the underlying pull. And this says rarely do a plantar fascial release. I've been told by other foot ankle surgeons that they actually commonly do a plantar fascial release because plantar fascia usually is contracted, and this actually helps with flattening it out. Again, if it's persistent varus, once you've done the osteotomy in the forefoot, you move towards a hindfoot osteotomy. And again, check the Achilles tendon and move down more towards other smaller procedures. So plantar fascial release, this is actually a very small incision of the medial side of the foot. Tuck down to the plantar fascia, basically transect the whole plantar fascia. There are reports of having complete collapse of the foot, but if you have a cavus foot, you got so many other issues going on with causing this deformity. This is probably unlikely. This is a very common one, especially in patients that have a overactive peroneus longus and a underactive or weak peroneus brevis. So the peroneus longus pulling the forefoot into the deformity. So basically, if you transfer that tendon to the weaker peroneus brevis, you can kind of offset by decreasing that pull, but then also augmenting the weakened peroneus brevis. So incisions made over the anterior margin of the peroneus longus, made down to the tendons, identify the peroneus longus, and as distally as possible, cut it. And with the foot held into as much eversion as possible, you TNDs the two tendons together. The forefoot procedures, as mentioned, was the metatarsal closing wedge osteotomy. This diagram actually included both options here. So one is you take a wedge of bone out of the metatarsal proximally, and you close this down. So this is going to decrease your arch height or decrease your Meares angle as well. Another option is to actually do a plantar opening wedge osteotomy, which is actually much harder, I feel, for the medial cuneiform. Authors also describe kind of doing both. You first do the metatarsal osteotomy, and if you don't get enough correction in the forefoot, you then do the cuneiform osteotomy. Again, this is mostly due to a forefoot-driven deformity as well. So X-rays down here, kind of hard to tell any difference in the imaging, but if you look at sort of the, I should have actually drawn it out, but Meares angle here, much steeper on the uncorrected foot, much more neutral or towards zero on the corrected foot. There are quite a few different osteotomies of the calcaneus that are described. This is probably the most simple. Basically, just translate the calcaneal tuberosity laterally, which is trying to correct the moment arm and the vector of the Achilles tendon. This is another one where they do the same thing where they translate it laterally, but they also try to dorsally translate it. This is to decrease the plantar arch and actually increase the length of the foot. My feeling is most surgeons that treat these kind of deformities kind of do a combination of whatever they feel is most appropriate for the patient at that time. And this is probably the most interesting one out of all of them, I thought. This was a Z-type calcaneal osteotomy. It's basically trying to get correction in 3 different planes. So the osteotomy is actually a Z-cut here with a wedge of bone removed. And so in the axial plane, they're tilting the calcaneus into more of a valgus and lateral position of the tuberosity. That's going to affect the pull of the Achilles tendon. In the coronal plane, they're closing down this wedge of bone that you removed down here. That's also moving the foot into a more of a valgus position as well. And then with this Z osteotomy, with this wedge being removed, this is actually decreasing the height of the calcaneus and decreasing the pitch of your decreasing the calcaneal pitch. I have done one of these. It is pretty hard to get this done correctly. And then the last one for treatment of a foot that is fixed, plus a lot of arthritis for patients that's usually non-weight bearing, it's just a triple arthrodesis. This is the one described in the Mann's foot and ankle Bible, where it's called a beak osteotomy, where you basically make a normal osteotomy, but you're keeping part of the talus to help correct or help keep the foot in alignment. It's a very hard osteotomy to do, much easier to draw out. So over the last 25 years, there actually have only been about 20 studies published, or clinical studies published on patients with this deformity. And most of them, as you can see here, this is just the last like 10 years or so. Most of them have a very small patient population. So 21 feet, 13 feet, 9 feet, 41 feet, 19, 22. So small cohorts. All are level 3, level 4 studies. The procedures done in each of these groups, this is just naming the different types, is substantial. So there's no consistency between any of these. Follow-up is usually pretty small as well. This one's pretty long down here. Again, idiopathic, neurologic, traumatic, it really varies across the board. There really are no good studies looking at what the outcomes are. It basically comes down to how much the surgeons train at doing these procedures, what their experience is with their prior mentor, and kind of their discussion with the patient, kind of what the patient wants as well. So overall, various causes of the deformity. It is a complex progression of the deformity. Hopefully it made it a little bit clearer, not more complex. Numerous procedures, yet limited clinical data on all these procedures. The Achilles foot can have a profound impact on the gait of a patient and also lead to significant arthritic changes and disability. Going forward, larger studies are needed with more consistent treatment options or treatment designs and better comparison between all the treatment types. Understanding the different etiologies as well, and more work on the joint sparing procedures I think is important going forward. All right. Thank you.
I think to look at this subject and try to memorize it, all these different steps is futile. I think that too often as orthopedists, we focus on the bony deformity, but in this situation, it is an evolving deformity, mostly from muscle imbalance.
Right.
And so pointing out the anatomy or understanding the anatomy of the foot and the functional anatomy of the major tendon forces that are contributing to this deformity and imbalance. In the early days, there were a lot more of these. The articles in the last 25 years maybe are a little different etiology than that in the first part of the 20th century, when polio was very big and there were a lot of claw toes. Intrinsic minus of the foot gives you a setup for a cavus foot.
Right.
And just like, the intrinsic minus of the hand due to the imbalance. So I think that this may have seemed overwhelming for the first row here today, but I think it points out how important it is to understand functional anatomy. The muscle forces, because that's what you use to try to rebalance this foot. And once there's fixed bony deformity, you need to deal with that before the soft tissue balance, can accomplish a correction. And so by understanding this deformity or the other ones we see, you become far more than just a bone doctor, but you really can sense the dynamics of how these things evolve. And so, the cavus foot is really a classic example of the evolution of the bony deformity starting from soft tissue imbalance. Anything to add, Brad?
Yeah, this was a great review. I don't know, in preparing this talk, Ben, if you come across some of the issues with athletes with this problem. It's certainly, there's lots of stories of even high-level athletes going through a couple lateral ankle instability surgeries that have gone on to fail, and then the problem has been, usually it's not a severe cavovarus foot, but there's some degree of cavovarus deformity that there's just no way you're going to control that ankle with a soft tissue procedure.
Right.
And, and then the issue with metatarsal stress fractures, particularly in basketball players. I mean, there's lots of stories about guys that just, they've had a screw put in, it's failed, screw put in, it's failed, bone graft, and then finally somebody does an osteotomy and they get it to heal.
Right. Yeah, there's some papers saying that in some athletes, it's actually a higher rate of a slight cavus foot because it gives you more of a rigid lever arm, potentially increasing your power with push-off. But then would also have the issues of creating more of a propensity to have injuries like a stress fracture or lateral ankle instability if you're playing a pivoting sport like basketball or football as well.
And we have not had particularly good luck putting the cavovarus foot, subtle cavovarus foot in an athlete in an orthotic. You'd think you put them in an orthotic, and in some ways it seems to worsen the lateral overload.
Yeah. Yeah, the art of orthotics is really difficult, but that's a very common complaint as well.
Brad, is a calcaneal osteotomy to shift the point of contact of the heel one of the more common things that you do when you have significant bony deformity in the athlete?
Yeah, I wouldn't say it's common, but I would say that we had a few cases at West Point where, we just could not control the instability with a soft tissue procedure. Bill Hamilton was our consultant, foot and ankle consultant, and he'd come up and, we'd have to do a calcaneal osteotomy, which for a young athlete, you would think is a, large procedure. To be honest, they recovered from it quite well. It isn't a particularly morbid procedure.
Right. Yeah, very small incision, pretty small dissection, good fixation, so usually heals very well.
How many have been involved in a triple arthrodesis? Yeah. No, I think this was a fairly common procedure years ago because those deformities had become rigid and bony. And Gillette is a great opportunity to look at some of these things because of the neurologic issues that are out there. And it's often that underlying neurologic imbalance that leads to, these subsequent bony deformities. And so putting your mind's eye on the dynamics when you examine that foot and not just look at that static x-ray, on the computer, I think really helps you to understand what's going on with a lot of these progressive conditions.
Mhm. Yeah.
It was a really good review, and I think the impact is there are so many elements involved, and in order to sort them out, you need to think about the different contributors to the deformity, and that's why it teaches the principle of understanding orthopedics, I guess, and not just at the conference you always see the X-ray.
Right.
And so we tend to over-focus on the X-ray. And I think we need to think about those unseen forces that are underlying so many of the problems we deal with.
Yeah, the dynamic changes of the foot. Yeah. All right, thank you.
Good, thanks.